Welcome, everyone. My name is Philipp Schuetz. I'm a professor of medicine and clinical nutrition at the University of Basel in Switzerland. And I'm very pleased to share with you latest insights into the EFFE trial. This is just one in a series of subjects brought to you by Channel 1 on demand nutrition education. And so today we're going to focus on an important clinical subject, namely how to treat patients in the hospital with disease-related malnutrition. When I walk around my hospital and I see patients, chronically ill, elderly, medical patients, 1 in 3 of these patients is at risk for malnutrition. And of course, as a physician, I would like to provide the best care for these patients. Actually, I want to provide evidence-based care to these patients. So what is evidence-based care when we look at malnutrition? Now, certainly, evidence-based nutrition and evidence-based care, it's about clinical judgment. So we have to ask ourselves, if we see a patient like this, is it really disease-related malnutrition? Is it maybe a specific disease we can treat, or are there side effects from medication which cause malnutrition in the patient? Second, of course, it's also important to understand patients' values and preferences. So is it a situation where we want to treat the patient? Are our goals aligned with goals of the patient and the family? And finally, we need to understand whether we do have relevant scientific evidence to actually provide a certain nutritional treatment to our patients. And so the third point about evidence to provide a treatment, I would like to now focus my talk on. It has become clear for a long time that there is a very close and strong correlation between the risk of malnutrition and mortality and other adverse outcomes. So in this slide here, you see patients from our hospital where we screened patients for malnutrition over about a 6-month period. And you can appreciate that about 30% of these patients have an increased nutritional risk, here based on the nutritional risk screening of 3 points or more. And the red line here is the mortality curve in these patients. And so stepwise, with higher nutritional risk, you also see an increase in mortality risk. Now, this observational study tells us that these patients are at risk for mortality, but unfortunately, it doesn't tell us whether the use of nutritional support in these patients actually can reduce mortality. So, in other words, we know malnutrition is a very important risk factor, but we do not know if malnutrition is really a modifiable risk factor. So, can we be active about it and actually improve outcomes in patients? And this was the aim of our Lancet publication of the EFFE trial. EFFE stands for Effect of Early Nutritional Therapy on Frailty, Functional Outcomes, and Recovery of Malnourished Medical Inpatients. So the trial aimed to answer the question whether the use of nutritional support in patients at risk for malnutrition has a beneficial effect on mortality and other clinical outcomes. So in this slide, you see briefly how the trial worked. So first, we did screening in all the patients. And for patients in the intervention group, if they were at nutritional risk, we defined individual nutritional targets based on caloric targets. We had a protein target. Also, we had a micronutrient target, and we also had some other specific targets. And once we defined the nutritional targets, we also defined an individual intervention plan, how to reach these targets. And as you can see, there were 3 levels. So first level was oral nutrition based on hospital kitchen, but also based on ONS, oral nutritional supplements. Level 2 was then escalation to enteral nutrition. And for patients with gastrointestinal failure, we were able to also use parenteral nutrition. So this was a randomized trial, and you see we first screened patients for risk of malnutrition. And if we had patients that were at risk, we had inclusion criteria which were quite broad. So nutritional risk, estimated length of stay of 5 days, and written informed consent. We had a few exclusion criteria. Basically, we excluded patients in post-operative patients, surgical patients, intensive care patients, also patients in terminal condition, or patients on long-term nutrition, because we were not able to randomize these patients. So patients were then randomized either to an intervention group, which was treated based on our interventional plan, as I have shown you before, or they were treated in a control group where we did not provide extra nutritional care, but we had just patients were able to get food from the hospital kitchen as they wanted, but they were not motivated to increase their caloric or protein intakes. So we then also had blinded outcome assessment after 30 days and 180 days to understand whether the use of nutritional support in the patients has an effect on clinical outcomes. But this is the most important result slide from our trial. And so in the upper panel, you see the risk of severe complications in both. In red is the intervention group, so the group that received nutritional support, or blue is the control group without support. And on the bottom, you see the same Kaplan-Meier curve for mortality. And so we found that the use of nutritional support had a very strong effect on complications risk. So we reduced the risk of complications by about 4%. And so if you count the numbers for a number needed to treat, you see that for every 25 patients that you use nutritional support, you are able to prevent one severe complication. The same is true for mortality. And so you can see here for mortality, for about 40 patients where you use nutritional support, you are able to save one life. So the trial proved that screening for malnutrition and use of nutritional support has very strong effects on clinical outcomes, reduces complications, and reduces the risk of mortality. We also had some other endpoints, such as quality of life, such as functional endpoints, which were also significantly improved by the use of nutritional support. So this study did really have a positive effect and also a positive echo. You see on the Lancet, on the title, they wrote that the EFFORT trial has provided evidence to substantiate the aphorism of Hippocrates, who has said many years ago that malnutrition and bad appetite is one of the very important factors in disease where we can have a positive effect. But since him, we really haven't had the strong data to support that malnutrition can actually be looked at as a modifiable risk factor. So when you look now at the EFFORT trial and to compare it to other clinical trials, it's of course also important to pool these different data to understand, well, is this just one trial that is positive, or is it really something that we have seen throughout the literature? And so after the completion of EFFORT, we did also finish meta-analysis, a systematic review and meta-analysis, where we included all trials that have looked at the effect of nutritional support on medical outcomes. And so when you see this slide here, this plot here, you can appreciate that overall, when you look at all these different trials, we have about almost 6,000 patients in the different trials. And you can see that overall, there is about a 30% reduction in the risk of mortality associated with the use of nutritional support. So nutritional support is really a game changer in the patients with malnutrition. Now, of course, one trial is important, and we used a very similar approach to all these patients. And then an interesting question is then also, well, should we use the same approach for all patients, or can we individualize nutritional support? For example, based on a patient's phenotype. Now, why is this important? Well, it is important because patients may react differently to food, of course. And it's also important when you think about the role of loss of appetite in patients when they get sick. And you all know, if you get the flu, if you get sick, the first thing that happens is that you have no more appetite. It happens in our animals, in our dogs, in our cats. It also happens in our children. Now, the dogs and the cats and the children, they have an advantage because once they are not ill anymore, they will catch up with eating and they will not have a deficit in calories and proteins. But our chronically ill patient, who is chronically ill and who has a low appetite for a longer period of time, now this patient has not the chance to catch up, but has a prolonged appetite loss and so a prolonged weight loss, which then causes malnutrition and sarcopenia. So while the effect of malnutrition, of loss of appetite, may be protective in our children and in a healthy subject, it is not protective in our elderly polymorbid patient population. And so it seems that the inflammation reaction is one of the key factors which reduces appetites, because cytokines, they reduce appetite in the brain, but they also have effects on your guts. And they also have effects on a cellular level with an increase in insulin resistance. So based on our trial data, we also asked the question, well, could inflammation be an effect modifier for the effect of nutrition on clinical outcomes? And so we stratified patients from the EFFORT trial into different groups based on their inflammation status on a mission. And as you can see on this slide, while overall we had a mortality benefit associated with nutritional therapy, this was also true for patients with low or moderate inflammation. However, in the patient group with very high inflammation, so this was here measured with a CRP, C-reactive protein level of higher than 100, you see that this patient group did no more have this benefit. And this was also significant in an interaction analysis performed in this trial. So it seems that the very high inflamed patients' nutrition does not have the same strong effect on mortality compared to the lower inflammation groups. So should we individualize maybe on other things such as patients' comorbidities? And so when looking again at the EFFORT trial data, we found that first of all, the risk of malnutrition here measured with the NRS has some association with the likelihood of responding to treatment. And so the higher the risk, the more we found that patients responded to treatment. Second, and this was unexpected and interesting, we found that patients with chronic kidney disease actually had the strongest response to nutritional treatment. So these patients with chronic kidney disease had almost halvening in the risk of mortality when they received nutritional support. So I think this is a patient population where we really should focus our efforts in to reducing, to using nutrition support and to reducing the risk of mortality and other adverse outcomes. Now, with COVID being all in our minds, and also with our data showing that the very highly inflamed patients nutrition may not be as efficient, of course, also it's interesting to look at the patients with a pulmonobronchial infection. When the EFFORT trial was recruiting patients, we did not have any COVID, so we didn't include any of these patients in the trial, but we had about 400 patients with pneumonia and other types of infections. And so we now also looked very closely at these patients with lower respiratory tract infections. And actually we found that this patient group also has a very strong benefit from nutritional support. So here you can see data comparing patients from the overall trial to patients with lower respiratory tract infections. We also did some other groups, COPD patients, streptococcal pneumonia patients, bacterial infection patients. And you see that we had a very robust effects also in these patient group with different types of respiratory infection. Now, finally, we also asked the question, well, do we see a legacy effect? In the EFFORT trial, we treated patients when they were in the hospital, but once they left the hospital, we stopped the nutritional care. And we just used it in some patients, but we did not follow on with our nutritional intervention program. And so it was interesting to see, well, what happens after six months. So we had about 2 weeks of treatment intervention, and we found significant improvements after 1 month. But would these improvements also last for 6 months? And so we just now finished our long-term analysis, and actually we found that in the first 30 days we had positive effects, but these effects weaned off after a while. And so I think these data show us that we need to continue nutrition support once patients leave the hospital. So it's not enough to just treat patients and provide nutritional care in the hospital, but if a patient has a persistent risk for mortality, you need to carry on your treatment for these patients. So what is our current concept of malnutrition? Well, I think first we know that acute and chronic disease cause sarcopenia or malnutrition and is a very important risk factor for adverse clinical outcomes and mortality. We know there are several risk factors which seem to be responsible. And we have inflammation, we have endocrine changes, we also have the immobilization of patients when they're sick. And of course, then we have disease-related anorexia. And I think we have learned from the EFA trial that we should be active about disease-related anorexia and treat the patient with nutritional support, because we have learned that malnutrition really is a risk factor that is modifiable. So what we need to do now is really also bring out the message to our colleagues, to the internists, also to students. And we have recently written a short update in the Annals of Internal Medicine. Why should hospitalists get involved in patients with malnutrition? And so I think it's a nice overview again, how we can provide the best care to these people. So I think first of all, we need to have screening tools where we are able to identify patients at risk within 24 to 48 hours. Second of all, we need a patient assessment. We need to understand whether it is really disease-related malnutrition or whether there is a specific disease we can assess. Is it cancer? Is it neurological disease? Is it maybe drug-related effects? Is it depression or other conditions? And once we have excluded such modifiable diseases, then we need to go on and define a nutritional plan for patients. We should consider calorie requirements, protein requirements, micronutrient requirements, and then also in conjunction with the team of dietitians and the nursing staff, we need to establish a nutritional strategy to reach these goals. This should start with oral nutrition, with hospital kitchen, but also ONS, and we can escalate to enteral or parenteral nutrition. So I think it's important today that we practice evidence-based medicine. And in terms of nutrition, I think it's very important that we practice evidence-based nutrition. And I think we have learned now from several trials that nutritional support has a beneficial effect on clinical outcomes of patients. So today we do have the evidence needed to be more active about nutrition in our patients that have a risk for malnutrition. And I think we should really be more active about this disease. So in summary, there is increasing evidence that malnutrition is a modifiable risk factor for hospitalized patients with chronic multiple illnesses. We have learned that proactive screening of patients using a validated tool and start of nutritional support protocols should be implemented in the hospital setting to reduce mortality and complications of patients. In the future, I believe we may need to further individualize nutrition according to specific situation of our patients, including maybe kidney function, including inflammatory status, and maybe we find some other disease modifiers that will help us to select the patients that have most benefit from nutritional care. So with that, I'd like to close. I would like to encourage you to watch for upcoming Channel 1 videos on nutrition and learn more about nutrition from my esteemed colleagues. And I'd like to thank you for your attention and wish you a great day. Thank you very much.